aldosterone is at its highest levels at presentation for acute MI. Now, given that high aldosterone levels are predictive of poor outcomes regardless of heart failure, there was certainly a rationale for the ALBATROSS trial. And in the April 26th issue of JACC, you get the results of the early aldosterone blockade in acute myocardial infarction, or ALBATROSS randomized clinical trial. And to talk about it, I'm with Professor Gilles Montalescot, who is from the Action Study Group at the Institut of Cardiology at the University Hospital over in Paris. Let's first off talk about ALBATROSS. What was it designed to look for?
You know, we had prior studies that looked at aldosterone blockade in heart failure. We had prior studies looking at heart failure and how we can impact the mortality of heart failure with this kind of drug, eplerenone, in the Ephesus study, for example. And we had a small study in acute MI, which was a reminder study, which was positive with eplerenone to reduce a number of events and the suspicion of heart failure measured by BNP levels. And we were able to show that this kind of intervention was able to control the BNP levels. It's not a clinical endpoint, obviously, and we wanted to have a clinical study with a clinical endpoint. So what we did is to look at these MI patients, both types of MI, STEMIs and NSTEMIs, and to look at this time frame where Ephesus was not involved. Ephesus started 3 days after the acute phase. We looked at these first 3 days and randomized the patients during the early phase of acute MI. Some of these patients were even randomized in the ambulance with our pre-hospital system. And we randomized the patients to receive aldosterone blockade using a generic drug which costs absolutely nothing. It's less expensive than aspirin versus standard of care. And we expected to see a benefit in these 1,600 patients randomized. And actually we were disappointed because we didn't see a significant effect in the global population. There were trends, but nothing significant. And we looked at subgroups, found out that the STEMI population behaved better on aldosterone blockade than the NSTEMI population. So this is a new hypothesis that this drug may work better in STEMI patients, possibly reducing deaths. We had a significant reduction in deaths in the STEMI cohort of patients.
Could it be that the patients with NSTEMI and ALBATROSS had less neurohormonal activation?
It's possible. It's possible, but we decided initially to have both types of patients because NSTEMIs are usually higher. Right. They have multivessel disease more frequently. They have also arrhythmias, and we expected to see the benefit, in both types of MI. Knowing the results, we would have to redo the study. We would certainly go to STEMI patients only.
Now, this was with a population of patients. It didn't matter whether they had a history of heart failure or not?
No, we could enroll any patient presenting with an acute MI. More than 90% of patients didn't have a prior history of heart failure and did not have heart failure at presentation.
Good, okay. And in the accompanying editorial comment, Bert Pitt, who is certainly appropriate for writing this, said, "We still need an adequately powered prospective randomized trial evaluating safety and efficacy, because part of the reason, he says, is the actual event rate that you saw was less than what you had projected, and so the trial was underpowered to evaluate the spironolactone effectiveness in these patients." Is that correct?
That's perfectly correct, and clearly we have 1,600 patients. We probably would need 8,000 or 9,000 patients. Obviously, the pharma industry is not going to pay for a generic drug trial, and it's very difficult to fund such a study. I would be happy to see a new study performed with this drug. I'm not sure we will see it.
Yeah, I mean, he says it would have to be probably governmental agencies that would have the resources because, like you said, the drug is so darn cheap. Dr. Pitt also wrote, it would be penny wise and pound foolish not to further evaluate this strategy given the data. Do you agree with that?
Oh, yes, I fully agree. I mean, this class of drugs is incredibly effective in heart failure. It's probably effective also outside of heart failure, especially in STEMI patients, but we need more data. We may get more data with a new generation of drugs. They will be developed in heart failure first. I think MI will come later. It's unfortunate, but we will have to wait. and these drugs will be more expensive also. So I think we would have to wait for further developments with the new drugs, unless some government wants to pay for a new study. This one was paid by the French government, actually.
Well, congratulations first off on getting through this study, this ALBATROSS that you've had around you for a while. And in the April 26th issue of JACC, you can see the paper by Professor Montalescot and his groups, as well as the editorial comment by Dr. Blockade. For CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.